Hello, everyone. And sorry about the technical issue about sharing the slides, which now has been resolved. It's a great pleasure to be here with you today, and I thank Ariel and the organizing committee for the very kind introduction. So my name is Abd Tahrani. Till recently, I was working at the University of Birmingham, and I'm still an honorary senior lecturer at the University of Birmingham in the UK and a consultant endocrinologist. More recently, I moved to work in Novo Nordisk with the clinical drug development in the obesity department. So these are my disclosures. I just want to say that Novo Nordisk has no role in this presentation whatsoever. So today I was asked to cover about the clinical implementation of the guidelines, and just put here a screenshot of the guidelines. This is what this is the guidelines which I'm covering in my talk. I will not go into depth at all. I'll try to focus and merge between the experience on how do we apply this in clinical practice, reflecting on our practice in Birmingham on when we started the diabetic neuropathy clinic. So just a little bit of background about the diabetic neuropathy clinic in Birmingham. This was established in 2012. At the time, I was working with Professor Martin Stevens, and we both collaborated to establish this clinic. The number of clinics that treat people with diabetic neuropathy in the UK is limited. There are lots of neurology clinics, but clinics that are specifically targeting diabetic neuropathy are very limited. The clinic was based in Birmingham Heartlands Hospital, which is one of the two teaching hospitals in Birmingham in England. And when we started, we were a small team, which we were clinicians, supported by a diabetes nurse and a healthcare assistant. But also we had a network and close liaising with a lot of other services, including the insulin pump team, podiatrist, the pain clinic, the neurologist, access to psychology, access to imaging, access to neurosurgeons when we needed. There is lots of entrapment neuropathies in people with diabetes. We also had access to the orthopedic surgeons and neurophysiology and many other departments. So it's important to, when you think about setting up any diabetic neuropathy services, is to think about the collaborations you need. You don't need to have large clinics per se, but you will need to have a lot of collaboration, close links with multiple services who you will need them either for diagnostic purposes or for management purposes. When we started the clinic, our target population was patients who have either painful diabetic neuropathy, or they have diabetic autonomic neuropathy, or they have Charcot neuroarthropathy, or diabetic amyotrophy, or any other rare neuropathies that can also occur in people with people with diabetes. Initially, we thought that the main function of the clinic will be actually to treat patients. But then we found that there is also quite a high load of diagnostic workload, i.e., we, instead of spending almost 80-90% of the time in the clinic treating people, I think we will probably spend half the time diagnosing and half the time treating. And the diagnosis part is very important, and Professor Papuzzi has alluded into that in her talk. We get a lot of referrals with potential diagnosis of diabetic peripheral neuropathy, painful or painless, but we actually have a high proportion of people who either do not have diabetic neuropathy or they have another form of neuropathy in addition to diabetic neuropathy. So it's absolutely essential in the story, in the clinical history and the clinical examination to be able to differentiate and determine and identify those patients who either do not have diabetic neuropathy and hence they require a whole different treatment altogether, or they have diabetic neuropathy with something else, which also require specific treatment. And in order to, the guidelines suggest in order to be able to diagnose diabetic neuropathy, you need to do screening, clinical diagnosis, and confirmatory testing. And this was covered by Professor Valenci and Professor Papuzzi in their talk. There are multiple tools that can be used to screen people, including quick foot exam and using validated questionnaires. Clinical diagnosis can also be based on a combination of clinical examination and the use of validated questionnaires, and the use of, when we say clinical examination, we need to take care of trying to cover different aspects of the peripheral nervous system, namely small nerve fibers and large nerve fibers, and then confirmatory testing with using nerve conduction studies for large fiber neuropathy or intraepidermal nerve fiber density for small fiber neuropathy, or corneal confocal microscopy, as I'm sure will be covered by Professor Riaz Malik. In our clinic, we had a battery of tests. We used the DM4 questionnaire, the machine gun neuropathy screening instrument, the short form McGill pain questionnaires, and EQ5D5L. All of these were used as part of our routine care in the clinic, mainly to diagnose people with neuropathy, painful neuropathy, and as well as assessing the quality of life. We think it's obviously a very important outcome in our clinic to prove to our payers that we can improve the quality of life of our patients. We also had a battery of tests, including the foot examination using the tools highlighted by Professor Popuzzi in her previous talk, including the 10-gram monofilament sensation, which is an indicator of advanced disease. We did have skin biopsies to look for intraepidermal nerve fiber density for a subgroup of patients, especially those who were involved in our research program. We used the Vegas device to test for cardiac autonomic neuropathy. We also used Neuropad and pseudoscan to look for small fiber neuropathies, and occasionally we used quantitative sensory testing. And in terms of treatment, we had access to FREMS treatment, which is mentioned in the guidelines, which is basically an electrical pulse treatment similar to TENS, but different to TENS in the frequency and the frequency of the spikes and the amplitude of the electrical spikes given. We didn't have access to confocal corneal microscopy, and we still don't have access. We also didn't have access to portable nerve conduction studies, but we used to do nerve conduction studies in the traditional manner in collaboration with the neurophysiology. But we actually trained a healthcare assistant to perform all these testing and perform all these questionnaires before we even see the patient in the clinic. So a lot of the testing and the questionnaires were ready to us when we see the patient, so we can move on with the treatment and the management. And when we followed the treatment, we followed the guidelines. These guidelines are, which I just showed you at the start of this talk. They suggest this treatment paradigm for the management of painful diabetic neuropathy, and that was our guidelines as well in real practice. This is what we used. We used to start with either pregabalin or duloxetine, then a combination. Then we moved to other options as a third and fourth line treatment. Many of them are off license, and in severe cases we use opiates. Occasionally we use spinal cord stimulation, and we used FREMS treatment for those who were also very resistant to treatment. With diabetic autonomic neuropathy, most of the assessment was based on cardiac autonomic testing using the Vegas device, but we also take care of people who had gastroparesis, hence we use gastric emptying studies. We also had more other testing to test for the autonomic gut. And for patients who had genitourinary complications, mostly they were managed in liaison with the urologist. And for those who have constipation, the management was in close liaison with the gastroenterologist. And for sweating and gustatory sweating, we worked closely with our dermatologist colleague. And I'm just trying here to show you that you do need to liaise with other specialty when managing people with the diabetic neuropathy due to the complexity of the disease. For those who haven't seen the Vegas device, this is the Vegas device. This is an enlarged picture of a Vegas device. It's a handheld device. The patients will hold the two sides like this, and then they can follow the instructions on the screen with the support of our patients. And what the Vegas does, it does the cardiac autonomic reflex testing, looking at heart rate responses to deep breathing, to standing, to the Valsalva maneuver. And we also checked blood pressure response to standing. We did not do blood pressure response to sustained muscle contraction because we didn't feel it add much value. It can also give you a lot of frequency domain and time domain analysis, but these are far less important from clinical practice, and they are mainly for our research cohort. And we manage people with autonomic neuropathy, mainly focusing on lifestyle intervention and glycemic control and reducing their cardiovascular disease risk factor. But then depending on which part of the autonomic system is affected, we used to direct the management towards that part. However, it is possible to actually screen for people for neuropathy when using the existing services. This is a paper from our friends and colleagues in Sheffield, led by Professor Tesfaye, where they basically use the opportunity that patients are coming to retinopathy screening to take pictures for their eyes, to check for diabetic retinopathy, and when they have the eye drops, to dilate the pupils for the eye picture or retinal pictures. They use that time to do 10-gram monofilament test, measure the feet pulses, do a pseudoscan, and do a quick sural nerve DPN check, i.e. nerve conduction study in a way. And if the renal function was not done previously, then they did a renal function test and requested the urinary albumin creatinine ratio. So they screened for all the microvascular complications in one sitting, using that time gap that was offered by the patients waiting for their eyes to dilate for the retinal screening. And overall, they reported on 215 participants, 91% of them reported that they were either in favor or very happy, strongly in favor in the service. Of this, what they call one-stop microvascular screening service, with only 8.9% felt that it was neutral or they didn't like it. So you can see that actually people they don't have a problem being screened for the microvascular complications, including neuropathy, but we need to keep in mind that we need to reduce the burden on their time and the visit to the healthcare system and the professionals. So to summarize and conclude, I think setting up a service that can screen for DPN is feasible and acceptable by patients. It can be done during other interactions with healthcare systems, such as retinopathy, for example. Services to treat patients with diabetic peripheral and autonomic neuropathies are really needed, and they can have simple setup, but you need to consider the appropriate collaboration to provide all the diagnostic and treatment needs of these patients. And such services need access to wide services with multiple specialties. But I really say that I really enjoyed my time in the diabetic neuropathy clinic. Dealing with these patients is really very satisfactory. And with that, I would say thank you very much for listening.